which is being presented by one of the originators of the technique, my dear friend, Professor Antonio Lacy from the Hospital Clinic in Barcelona, Spain. Antonio is going to be speaking to us this morning about a very exciting, innovative technique employing an innovative technology, in part developed by Gerhard Buis in Tübingen and part of the technique by Jerry Marks, but I don't want to steal the thunder. We'll hear more about that from Antonio on transanal TME. So if we can turn over to Barcelona. Professor Lacy, good morning, good afternoon for you.
Good morning. Probably very early to you. Thank you very much for your kind invitation. And I wanted to talk not only dedicated to transanal total mesorectal excision, because I think that this approach is something more just indicated to rectal cancer. And we call it TACRES, it's a Transanal Colo-Rectal Endoscopic surgery, because you can see we can do many procedures, probably more indication that we did it at the beginning with my dear friend Patricia Schiller. We call Cecil approach because our logo of the Advanced Surgery channel is two lions, and we decided to join in one lion because Cecil, it was a lion killed by a human being, and I think it's an ideal name to talk about this new approach. Going to the minoinvasive surgery in colorectal, there are some pros and some cons. I think it's no doubt laparoscopy you can see better. It's too much, related to the individual skill of the surgeon and experience in hospital, etc. And it's no doubt we have the advantages of minoinvasive surgery, talking about morbid mortality and return to normal activity of our patients. However, let me say something. It's too difficult. I think sometimes a pelvic and tumor dissection could be very difficult in an obese and male pelvis. Many people is talking about closing rectal stem. I remember, because probably I'm getting older, I remember when I did, in my bosses used to do the rectal cancer by open approach, and I did some cases with an stapler. The length of the stapler was 30 millimeters. It's a 3M stapler, TA stapler, and we used to close the rectal stem. Now I don't know what's happened. Probably in the 25 years we have an evolution in our rectal because now we are using multiple firings of 45 millimeters, and nobody is closing the rectal stem with one simple firing, and many of them is using the majority 2 at least, and sometimes even 3 or 4. Maybe it's one of the reasons because with the problems that we have around the world, we have a bigger rectal stem. Another important thing is the obesity and conversion rate. The majority in experienced centers, conversion rate is something between 5 and 10%, but many places, many hospitals, when they include all comer patients, probably the conversion rate is more than 15 or even 20%. The most important is no doubt is try to follow the principles to do good quality of total mesorectal excision. And another important thing, something around 10%, is talking about leaks. What happens if we have a patient with narrow pelvis, obesity, we have to close the rectal stem, we have a bulky tumor, we have a bulky mesorectum and mesocolon? Maybe a good alternative comparing with open and laparoscopy is to make the transanal approach. But let me see this video, and I think it's important because we call from the transanal approach of the 2 teams to the Cecil approach. And if you go to the history, that is the first case that we made it with Patricia. Thanks to her generosity, because she came to our hospital. I remember exactly, I arrived at the hospital at 6:30 in the morning with a pajama from the Barcelona hospital. She was pregnant. Actually, the reality is 34 weeks pregnant, and she lied to the pilot because she has to, to be not allowed to take the plane. She arrived, and we did it. We changed the technique because we decided to do with different platforms with this approach, and I think it's not for us, it's mandatory to use in the two teams. We have new system, new devices to have a stable cavity. I'm talking about the new insufflators. It's a continuous insufflators instead of intermittent insufflator. In this we are cutting all the rectum, and now they have many tricks and pitfalls. If you have this, it's something really, urgent to close, because you can make with the pressure of the carbon dioxide, you can make, some spillage into the colon with the tumor. Now you can see, that is not the right way to do it, but you can see perfect the right plane. That is the most important thing. And that is the way to do it. Try to find in some place the right plane and continue all absolutely confidential to do a good oncological technique. In this case, we made too much dissection in 270 degrees, and you can see to the right side of the patient all the rectal stem. In this other case, it was a very difficult case. One of the main problems of this, we have new injuries like a urethra injury. Fortunately, we realized before cutting the urethra, but there are some data in literature, and I have some rumors there are many places you can make it. That is another thing. Sometimes you go too down, and we make an injury in the presacral vessels. But in this approach, it's very easy to make the hemostasis. Another good trick is when you decided to do the through string from the rectal stem by endoscopic view, it's much better to do it anti-clockwise. Another anastomosis, a recent paper published by expert groups. There are 4 or 5 different ways to do the anastomosis. You can make everything into the abdomen, you can make out to the abdomen, you can retrieve the specimen through the incision, abdominal incision, many things. You can do a torticolectomy with a J pouch, and you can treat complications. That is actually a patient operated with a sigmoidectomy 24 hours before, and the patient has an important hemorrhage, and we decided to come back to the operating room and to put a simple stitch after 3 flexible endoscopy that they did not solve the problem. It's a very easy way. Probably that is the way to treat leaks. I know that could be an important tool to treat our complications. Since November 2011 to September 2015, we made almost 230 patients. Now it's 270 patients, and the majority is rectal cancer. We do 20 ulcerative colitis and reduce now in more than 25 patients. The mean age is 65, 60% are male, BMI something between 18 and 36. We operate recently a BMI of morbid obese because the BMI was 46 and without any problem. Previous surgery is 50 patients, 26%. The majority of those patients are in mid and low rectal cancer. Many places indicate this approach only for low rectal cancer or maybe mid rectal cancer when they decided to do a total rectal incision classical, but now we are doing in high rectum or even rectal sigmoid cancer patients because sometimes, you know, the approach with the two teams could be much better. In terms of the staging, there are many of them are treated 60% by neoadjuvant therapy, and you can see for us it's not, the T4 is not an exclusion criteria to make this operation. In surgery, majority of the patients, mid and low rectal, we decided to do a total mesorectal incision. Majority of them also, we made it a stapler anastomosis, 75%. And let me say, unfortunately, 78% is still with a developing stoma. But now, from the beginning, you know, it's a good data because your conversion rate is 0%. That is the same experience with many places around the world. You know, that's probably something, you know, because in the beginning, when you're starting with the technique, you're beginning, probably in the rectal cancer by laparoscopy conversion rate is something around 20%. Assisted incision to retrieval anastomosis, you know, we made it in 33% of the cases, and because the target is not to do a pure knots procedure, that like all the surgeons made it in an endotical way. However, if you have any doubt, my recommendation is, okay, do it, make an incision to take out the specimen. Surgical time, the majority in open or laparoscopy is something between 2-3 hours, even more. But when we are starting with the two team, we reduce almost to the 133 minutes. And believe me, we did cases with less than 50 minutes, all the procedure, including the ileostomy. And that's probably it's a trick because you have two teams operating at the same time. But I think I have one of them, actually the chair, can confirm we can do this procedure in a very good way, and that's probably good for the patient. In the first 50 patients, the mean operative time was around 200 minutes. In the last 15 is less than 2 hours. Starting diet is a median is 2 days, soft diet 3 days, and discharge median 6 days. Probably something related because our ethical committee, we have to wait 6 months to be approved by the ethical committee of the hospital to have the permission to do this approach. And after that, the ethical committee, you know, obliged to us to send the first 100 patients the results to them because they wanted to follow all this different approach. The specimen pathology, you can see here the complete response is only in less than 50% of the cases, and you have in the end stage N0, you know, after many of them treated with neoadjuvant therapy is something around 70%. If you go to that is really important because one of the main things, and let me say about experience and tricks, is when you decided to do open or more importantly laparoscopy, and you decided to operate a patient with a rectal cancer 6-7 centimeters from the verge, you decided to close the rectal stem. How is you measure you are in the right place or not? The majority is using the finger of the surgeon introducing to the anus, or even a colonoscopy or rectoscopy during the procedure, and you put the stapler, you know, the endo-GIA to close the rectal stem. With this approach, it's an advantage because you can see where is the tumor and you can decide exactly where you wanted to cut the rectum. In the serum, positive is positive in less than 7% of the cases, and the mesorectal quality is, in the majority of cases, 96% in the grade 1 is a complete mesorectum. That is very important because the pathologist is our audit to control our surgery. In terms of the complications, I remember when we started the first 20 cases, we didn't have any leak. Unfortunately, now we have 8%, 16 cases leak, and something is probably related. We can discuss about that because we try to find a solution, and I think it's no doubt something is related with the blood perfusion, the vascular blood supply of the anastomosis. And the second thing, maybe we can discuss also, is the type, the quality, the design of the staplers, because we're using a stapler quite modified to use this technique. We have no mortality and only less than 10% readmission rates. In the follow-up, that is still preliminary. I hope in the next stages, in next week, in 2 weeks, or maybe probably, no doubt, in the American Society of Colorectal Surgeons, we can show you the first results comparing 37, laparoscopy 37, with midterm results with a follow-up minimum 3 years, and I can introduce the survival. We're very happy because we have, I think, quite good, excellent results. If you go to the Kaplan-Meier curve, you see it's an excellent results in terms of oncological point of view. If you go to the literature,
Yeah, maybe just before we do the literature review, if I could just jump in here, please, just to congratulate you on some wonderful data, ask you a few questions, and also go around the audience a little before you talk about the literature review. Just firstly, to kind of give a little bit of definition, you talk about the assisted incision in 33%, but zero conversion, and you mentioned that the incision was to retrieve the anastomosis, but I'm sure you mean to retrieve the specimen, right? So the assisted incision is strictly if the specimen's too bulky to bring out transanally, then you make an abdominal incision. Perhaps you could just clarify that issue of the assisted incision versus conversion.
Correct. That is really important because we never use this incision to do any dissection, anything. It's just to retrieve the specimen because we think, the tumor is too bulky, or maybe the mesocolon or mesorectum is too big to take out the anus.
And we're going to maybe go around with some other questions. The other question, Antonio, why wait 2.2 days to start a diet? Because you mentioned 78% of people had stomas, and even if they didn't have a stoma, why wait 2.2 days to start diet, out of curiosity?
Correct, probably because, I can try to find let me say a trick answer, but the reality is because in our organization it's very difficult, to educate patients. And we have, in the hospital, we are not doing a good fast track procedures in our patients. And that's probably the reason because, they are starting, diet, etc. Let me say, since 2 months ago, now we started with the diet exactly 2-3 hours after the surgery, even in the recovery room, because we implement now at the end, after 20 years discussing about that, and now we have a very good results. In terms of the hospital stay, is because probably we are very fear, to send patients with a new approach, new stapling devices, etc., to send patients to home, and the patient has a leak at home. We realize normally when we have a leak, it's never 6-7 days after the surgery. Normally it's 2-3 days after the surgery. But you are absolutely right. And I just wanted to say I apologize. That is not good result.
Well, no need to apologize. They're great results. Another technical question for you is the drain. I don't know if you mentioned it. I may have missed it. But do you use any pelvic drains in these patients?
Correct. We use in almost 100% of the cases in low and mid rectum, when you do a TME, drain minimum 24 hours. We try to take out as soon as possible. We don't like drains.
Okay, I'd like to go around to a couple of other sites, if I may, and maybe we can start at Lankanaw, because in many ways I think so if we can go to Lankanaw and John Marks, got a standing room only crowd there this morning, John, but it's really to go to the beginning. I think in many ways these transanal approaches started with your dad, with the TaTME operation more than 30 years ago at Lankanaw. Do you still use that standard approach, or have you converted everything to this approach? And if you use both, what makes you decide one versus the other?
Sure. Well, Steve, thanks. It's always great to hear what Antonio's doing and see that wonderful presentation. And I have to really applaud you for your productivity. That's an enormous volume of work in a short period of time. As Steve said, we have a deep interest in this dating back to really the mid-'80s, and this was with the TaTME procedure. And for us, we've used this procedure almost exclusively for cancers in the distal third of the rectum to avoid abdominal peritoneal resection. The original drivers for that in an open fashion was to obtain a known distal margin and avoid many of the things that Antonio has highlighted, the difficulty in knowing where to put a staple or even being able to do an anastomosis in the low rectum. From there it has evolved moving forward, and it's only natural to apply minimally invasive approaches transanally and extend this up cephalad, which is what we routinely do. I think that Antonio properly pointed out that this allows approaching the most difficult part of the operation for rectal cancer, which is the distal third of the rectum, is to take this immediately, and so that it very much facilitates things from above. So to answer your question, Steve, we pretty much, for the TaTMEs, we start them transanally because I think it's an easier, safer way to do it. It avoids this issue that's come up with in many centers about the urethral prostatic injury, because you have the ability to feel the rectoprostatic sulcus. But Antonio, I think if you could clarify, if you could tell us, what do you think are the essential aspects of doing the transanal TME? What makes it, what do you need to accomplish transanally to have this really be a transanal TME? And then the second question is a technical question, is when you're doing your EEA anastomosis for something in the mid-rectum, I've always found the challenge is, how do you tie the purse string around the post in the distal rectum, because it's difficult to get something to see what you're doing, as well as cinching that down around the anvil post. Thanks again.
Thank you very much. I think the most important in the rectal dissection is try to, actually we follow what you described, 20 or 30 years ago with the TaTME, because we try to find, we cut the rectum and we try to find a plane. For us, it's absolutely forbidden to use any seal device. We use a normal electrocautery, and we try to find the envelope of the rectum. And forgetting the other things, like when we mention in laparoscopy, we think it's not absolutely necessary to see the ureter if you maintain intraperitoneally. If you go to retroperitoneum, you can make an injury of that. In this approach is the same. Forget the nerves, forget the vesicles, forget everything if you are following, the envelope of the rectum. In the second thing you are mentioned about, when you do a high rectum, you mean how we close the rectal, how we made the purse string in the rectal stump to close the rectum, or what do you think? Because in the low rectum it's very easy, you can do a stapling, or manual is a very, very, low, but in the high, like the same thing. We do the purse string endoscopically, and we can check from the laparoscopy and at the same time from down.
Thanks, Antonio. I want to get a few other folks to weigh in. If we could go to Imperial College in London, I don't know if either Aradarzi or Paris TACRES is there, but you guys are big robotic enthusiasts, and I'm wondering if this is in any way, I don't see either of them, so it looks like maybe some of the senior registrars and lecturers maybe are getting stuck with this question, but if you could tell us how the transanal TME may have impacted the use of robotics for distal rectal cancer, if at all.
Hello everyone, I'm Marta. I'm one of the PhD students on transanal TME. I work both here at Imperial and with Royal Hompus from Oxford. I'm afraid we don't have any of our attendings here today, so I don't think we'll be able to answer your question about robotics. I did have two questions for Dr. Lacy though, if that's okay. One was regarding the selection criteria for patients who have transanal TME, because every surgeon I asked who's doing transanal TME seems to have a different answer. I understand for the mid and low rectal tumours what the benefits are from transanal TME, but maybe more for the higher tumours. I understand you were performing transanal TME for these cases as well, and whether it does convey much added benefits than doing a very good laparoscopic TME. And the other question was regarding the anastomotic leaks, whether you noticed any difference between hand sewn and stapled or different ways of stapling.
Thank you very much for your kind question. You know, the first thing is indications. Indications is now is in benign patients are all IBD that we decided to do a proctocolectomy. Familial polyposis is another very good indication. Second thing we have some experience in Harman reversal, because you cannot imagine how to dissect in the two teams approach, because sometimes all the small bowel is in the rectal stem scar, and sometimes it's very difficult to dissect all the small bowel. And with this approach is much better. Another thing is, for example, many of them have diverticulitis disease. You decide exactly where you wanted to cut the rectum. And the third, the majority probably, is all the complications like chronic sinus, etc., leaks, complication. In rectal cancer, probably is the main part of the patients, is no doubt, is more than 230 our experience now. We include all the cases. All means everything. No contraindication, all comers, previous operations, males, females, because many people say, that is ideal to obese, male, mid or low rectum. Why you need to use in a BMI 20 or in a female pelvis? My answer is very easy. If you do in an easy way in difficult patients, could you imagine in easy patients? You can do this approach in 40-50 minutes with excellent results. But I'm very, let me say, I'm very enthusiastic. My name is Irish, however, my problem, 90% of my blood is coming from the Mediterranean Sea.
Thanks, Antonio. Let me try that same question. Maybe we can go to IRCAD in Strasbourg, and I don't know if either Jacques Morasco or Joël Leroy in Strasbourg can tell us the same issue about the impact of transanal TME on the use of robotics. Who in Strasbourg would like to take that question?
Okay, so good morning. Joël Leroy is on the way back from Taiwan to Strasbourg. He's in the plane, so he's not there. So I am Didier Mutter. I'm here for you. We didn't start the robotic transanal TME. We perform only the direct approach, and we want to congratulate Antonio Lacy for his fantastic experience in this field. I think it's one of the most advanced team in this field. So we have one question here from Dr. Wiesmüller, who's in our team.
Hello, I'm the colorectal fellow here at IRCAD, and obviously my question addresses the pure nodes rectal resection that we sometimes perform here. because Professor Leroy performs this sometimes in patients that are, for example, fragile, or in patients in which there's uncertainty about the malignancy of the tumor, or sometimes even patients ask for this type of technique. My question to you is, what do you think of this technique as an added value? And if you do a pure transanal rectal resection TME, with what kind of port do you perform this?
I think it's a very good question, but let me say my answer is we are normal human beings. We're not excellent surgeons like you are, and we wanted to do something you can reproduce in the majority of centers. We have a course, and we invite, to this course, for example, our chairman. And I think the majority of people is coming to the hospital to take part of this course is minimum 2 per month. They do cadavers, they do, live surgery with us, etc. 80% of them started with the technique. If you decided to do pure nodes, probably only 1% can do this procedure. And at the moment, pure nodes, I think, is the ideal, is our dream, but at the moment with the devices, I think in our experience, we cannot perform in a right way in oncological point of view. Because for us, maybe the most important is to be, is the safe of the patient when you do this procedure. Probably only a couple of surgeons around the world can make this difficult operation like you, like Joel, made it in your center.
Antonio, while you've got the microphone, why don't you carry on with the presentation?
If you go to the, some data and literature, there are, something absolutely mixed, because if you go to the excellent paper by Renet, again from France, you have 30 cases, and the majority of them are, they wrote in the paper, they are very difficult cases, and they have sometimes some complications probably related with the case. Another group like Atala are very active in the United States. They do many of them. They do by robotics. They do many things, and I think it's an excellent experience. At the moment, probably we have to wait the new robots like the single port to do this approach much better. They are coming to Europe. In Italy, there are some papers with good results in terms, but the numbers are not really high. There are other groups, probably like in Holland, like Cecil, with I think excellent experience. That probably is all cases, because published in 2015, probably they have more than 100 cases, and that's I think excellent again. And I think we published in JACS a good paper with, I think, let me say, an important experience with more than 100 cases. And as I said, in rectal cancer, we have now more than 230. But what is it in the terms of the technique? Because now I think we can say we can do the same approach. And at the beginning, I used to say in front of Bill Hill and other masters of this surgery, say this approach is easier. Sometimes yes, and let me say now, sometimes not. You need to have all the devices. For us, it's important to have a view in 3D, a three-dimensional view to the rectal stump. We need to have new insufflators. We have to have a new adequate platform, probably the rigid platform coming from my frame. I remember very well Gerhard Bose, to do with this platform probably is not the ideal thing. The new devices are much better. At the beginning, we recommend 2 teams working simultaneously, and now I think it's mandatory. I think it's safer, and I think in oncological point of view, it's absolutely much better. We have some experience with tumors invading the uterus, invading the prostate, and I think it's much better if we have the view of the 2 teams. Another important thing is what are the take-home messages that I think is important. Remember, we are talking about TME, it's still the gold standard. You know, in many places they are even trying to implement after 30 years ago. Laparoscopy, I think, is good, but let me say something provocative. If I have a rectal cancer, I'm not sure if I can choose between laparoscopy and open. I don't know if I come back to open, because with the laparoscopy, the problem to dissect the mid-rectum and to close the rectal stem and to decide where you wanted to cut the rectum probably is a problem. To try to reduce the trauma, I remember every day Maurice Franklin, because when they started to do nose, you know, many people, including me, said, why, you know, this guy need to take out the specimen through the anus. And now we are doing it. Thank you again, Maurice. The new bottom-up approach is no doubt you can do it to 2 teams, and maybe it's time to do a randomized study. The main problem of the randomized study, you come back to the history, Color 1, cost, Color 2, the American trial, I'm sorry, you know, they ask, it's difficult to me to pronounce, you know, the rectal trial, and they take sometimes 7-8 years to recruit patients, and we need to wait at least 3-5 years follow-up to show the results. Probably we need to something better. It's no doubt the new robotics, the new approaches maybe could be the technology of the future, but we have to reduce the cost of this. Now it's time to work with the you demonstrate today, because now we are working in the different parts of the world at the same time, in early time for you, maybe time to go to take some tapas for us, or maybe in a couple of hours to take the siesta. But I think the way to work is not, we are not in the era of I, we are in the era of we, is no doubt. Cooperation is absolutely much better than competition. And I wanted to show you, that is the figure that my father put in my room when I sleep with my brother, and I think now, I have a new brother in surgery, and I think he's a good friend. That is an extraordinary picture, and you can recognize here Mariana Berho, you know, Steve Wexner, operating this Cecil approach.
Thanks, Antonio. Before we conclude, let me just, we got a few minutes left. Outstanding lecture, very thought-provoking. If we can turn over one center that I didn't announce, because I apologize, I didn't realize they're online with us, is Jewish General Hospital, McGill University. And if we could have chorus call go to McGill in Montreal. We've got a question for you, Antonio, from Dr. Boutros, one of our alumni. Good morning.
Good morning. Thank you, Dr. Lacy. We really enjoyed your lecture, and we enjoy watching your videos all the time. We were wondering if you could just step by step tell us for a mid-rectal or high rectal cancer how you put the purse string on the colon side, or how you make the anastomosis. For distal rectal cancer, we follow. But for mid or higher rectal cancers, if you could explain to us.
The trick is very easy. When you decided to do going to the high rectum, you leave minimum, let me say, 6-7 centimeters on the rectum. Probably is much better, you know, before you enter into the abdominal cavity, because when you communicate the 2 cavities, probably if something is not well, you cannot see excellent the rectal wall. And before you enter in, you make a push-string in anti-clockwise if you are a right-handed surgeon, and you do this. You take out the proline suture through one of the trocars of the platform, and you continue to operate. The main problem is you have to be careful, not to tie too much, because you can continue to operate and to enter into the abdominal cavity. You take out the specimen or through the anus or through the abdominal incision, and when you prepare the proximal anastomosis, and you do the anastomosis in a normal, standard way with this approach.
Abdominal incision. Thank you.
Thanks, Marilise. Thanks, Antonio. I want to just ask one other group, and that's the Mount Sinai School of Medicine in New York. Pat Silla was, Pat, there you are. So let's let you have the final word, since you started all of this and got us all on track. And specifically, I wanted to ask you a little bit about the learning curve for this type of procedure and what we're doing in the U.S. We've heard about what's going on in Europe. Maybe you could talk a little bit about the learning curve and about the activity in the U.S.
Well, thank you very much, Steve and Antonio, again, spectacular presentation. That's exactly how I wanted to conclude. I think the struggle that we have now is, Antonio, is figuring out how to get to where you are as quickly as we can. So I really would like to ask you what your thoughts are on a registry entry, auditing of surgeons' results, and then training. I think we are struggling to figure out a path for training, whether everybody should be mandated to start at least with cadaver training. Is it sufficient? What are the prerequisites before starting this operation? And how do we monitor surgeons to make sure they're ready to complete the procedure safely? What are your thoughts after the largest experience in the world?
We have, quite important experience thanks to you, Pat, because you made the first one in the world with us in the hospital. And I think your generosity, we have to follow, people like you. It's very easy to work with people like you. Second thing is no doubt, I think you have to, to plan this approach is coming to some centers with experience and to make, light surgery, to discuss, but not only, if I wanted to do this approach, I think it's not enough one surgeon coming, going to one hospital, one reference center to do this approach. I think it's much better. The best way is go the majority part of the team. That means minimum 2-3 surgeons and also nurses. You saw our nurses are, the surgeons are not very good here in Barcelona, but the surgeons are the best. You can do the procedure without any words, and you realize you were here with us, and you are, I think, you realize that is very good. Another important thing is cadaver, model is excellent. You have to do it. We are just, let me say, we are like in Barcelona. We have many people coming from Japan to make pictures, to guide these houses, and I think we are trying to copy, like Japanese style in terms of the cameras. We are copy like you made it long time ago. The calibers is very important. You can go also to animals in pig, but sometimes pig you need to have a pig with 50-60 kilograms. Sometimes it's complicated, and I don't like to kill more animals around the world. And after that, when everything is ready, probably the best way is to have some kind of mentoring, and maybe around the world, because now it's time, as I said, to the and we can do something all together. Registries is good, but sometimes, people are feeling, not everything. It's important to know exactly what is the main problem of this technique. As you said, we have a new complication with this technique. Nobody is, publishing literature, the urethral injury due to a low rectal anastomosis. And now we have, and many people have, And that, I think that is a problem related with the skills and education in this approach.
Thank you very much, Antonio. Superb presentation. We appreciate the effort you put into this morning's talk, plus, of course, the effort you put into developing the skills and teaching surgeons all around the world how to do this technique.